Good afternoon, everybody, and welcome to the webinar. Today, we are in our Hypertrophic Cardiomyopathy webinar series. Today's is the third in the series, and the topic today is living with hypertrophic cardiomyopathy. Just before we get started, a couple of notes to make your listening a little more enjoyable. All attendees are in listen-only mode. If you can't hear, hopefully you can read my slide. You weren't having the audio difficulties that I was having earlier. Check the audio button on your personal computer to make sure your sound is on. That's usually the issue. Please type your questions into the Q&A box anytime during the presentation, and I'll read your questions out during the question and answer period at the end of the presentation. The PDF version of the slides, as well as a recording of the presentation, will be available on the Mended Hearts website following the event. As a note, no questions regarding a patient's specific health can be addressed due to the fact that the presenter is not your treating physician. If you are new to Mended Hearts, our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. I am Andrea Baer, your Executive Director here at Mended Hearts. And with me, I have Dr. Matthew Martinez, who is the Director of Atlantic Health System Sports Cardiology at Morristown Medical Center and is a nationally recognized expert in hypertrophic cardiomyopathy. I am going to stop sharing my slides and allow him to take over. And Dr. Matthew Martinez, thank you for being here with us today. We're so thrilled to have you.
Well, thanks for having me. Let me see if I can do this right here. I'm gonna try and share. Now, do you see the full screen slides or do you see the partial screen slide?
We do see partial.
How about now?
Yes, perfect.
Oh, strange. Wait, hang on one second. Why is it doing that? Hang on.
It's a Friday and it says you don't want to work today.
Okay, so I'm sharing now, right?
Yep.
You see the condensed version. Now, you see full screen or partial screen?
Well, I see the full screen. We just see your next slide, which I think is probably fine.
Well, I'd prefer it if we didn't.
Okay.
Duplicate. Now, what if I swap?
I think if you swap, you might be good. I think that there we go. Now you're in business.
Show presenter view. Very strange. How about now?
Now I see, there you go, hide presenter view.
Normally, this is not the hardest part of the presentation.
Well, today it seems like just getting ourselves figured out is the hardest part.
Now,
you're good.
Full slide, right?
Slide.
Okay, so thank you for your patience. I'm Matt Martinez. I'm the Director of Sports Cardiology and Hypertrophic Cardiomyopathy here at Atlantic Health System. I have been here full-time for about 4 years. A few years before that, I was part-time while I still lived in Pennsylvania. And before that, I spent 12 years at the Mayo Clinic. I am excited to talk to you about something I do every day of the week. That's all we do here with this program, is to take care of those with hypertrophic cardiomyopathy, specifically some expertise in how we handle athletes. So I thought we would talk about the benefits of exercise in total, risk of cardiovascular disease and HCM, the potential harms, what's the controversy, and then some recommendations. How do you handle this in the current scheme? Because exercise for a lot of folks is a big part of your life, whether you're watching it, whether you're participating in it. and whether or not you have a family member that you might be encouraging to participate, exercise should be part of what you do on a regular basis. And it's important. Exercise modifies cardiovascular risk factors. It doesn't make HCM less so or more so. You can't bring on hypertrophic cardiomyopathy with exercise, but the coronary disease risk factors, the complications that the rest of us have, can all be affected, whether it's high blood pressure or lipoproteins like you're seeing here, cholesterol or body fat, or overall cardiovascular events. Exercise lowers all of those to improve cardiovascular outcomes. So it's true, exercise is truly medicine. And it goes a little beyond that. It's not just heart disease. It also lowers your risk for cancer, for lung disease, for type 2 diabetes. It improves your balance, your overall fitness, lowers your body mass, and it can be really important for mental health. So it's an important part of how we should be taking care of ourselves in total. And we're going to talk about how you might do that safely. So physical activities guidelines for everybody. This is the current recommendation from the American Heart Association. And they say 30 minutes of moderate intensity of aerobic activity 5 days a week, or 25 minutes of vigorous activity 3 days a week at 75 minutes, up to in total about 150 minutes, some combination of those, and high intensity muscle strengthening activity 2 days a week. So on top of that, about 5 total days of exercise for everybody, whether you have hypertrophic cardiomyopathy or not. So it's obviously talking about HCM in some level, because HCM is really everywhere, every continent, 120 plus countries. We know that this is common. 1 in 500 people, almost 90% of the world's population has had some description in that group of hypertrophic cardiomyopathy. But physical activity among HCM patients in general is often discouraged. Not always, but there's been a lack of focus on physical activity. And as a result, there's been less, HCM patients are less active than the general population. 60% believe the restrictions have negatively impacted them emotionally and their overall well-being. There's been a greater psychological effect, more elite and competitive athletes and those who are told to decrease the amount of exercise. They've felt the largest burden of this recommendation. And more than half, nearly 60%, don't meet the minimum guideline for physical activity that I just described to you. So who cares, right? Well, we know that obesity and hypertrophic cardiomyopathy is not a good thing. So this is the second paper. I'm going to show you just one. Over 3,200 patients published in 2019, looking at mean age of about 47 years old. Almost 1,300 were pre-obese in that 25 to 30 BMI, and over 1,000 over a BMI of 30. And what they found was that those who were obese had worse outcomes compared to those who were not. So the overall composite outcome, the heavier you are, the worse you did from HCM in total, and the more likely you were to have heart failure. So both of these show that the blue line across the bottom is a worse outcome compared to the top line. So the larger you are, the heavier you are, the worse the outcome. All patients with obesity were more likely to be symptomatic. There was an independent risk for heart failure, for atrial fibrillation, regardless of all the other potential harms. Left atrial diameter, obstruction, genetic status, age, and sex. It's an independent risk factor for adverse outcomes in HCM. If you develop heart artery disease or blockages of the heart arteries with HCM, it's even more of an increased risk. This is data from Paul Saraja at the Mayo Clinic almost 20 years ago, showing that if you have obstructive heart artery disease, the green line, you had a worse outcome than if you had mild or no obstruction at all. So this is a particularly worrisome finding if you have heart artery blockage plus hypertrophic cardiomyopathy. So what about the other side? What if you're fit? Does it actually improve your survival? And Mayo looked at this as well. Same authors, Dr. Amen and Paul Saraja, looked at this. and it was associated with improved survival. So this first upper corner shows that if you have a VO2 max, which is a measurement of fitness over 18, regardless of age, regardless of sex, and regardless of ethnicity, you did better than if your VO2 was under 18. So that can vary by age, and there's all kinds of issues with that number of 18, which is low if you're 25, but actually pretty reasonable if you're in your 50s or 60s. But if you look at it across the board and just look at VO2 max as 80% of your predicted, 60 to 80% or less than 60%, no surprise, the more fit you are, the better your outcomes are with hypertrophic cardiomyopathy. So there's a clear theme here. The more fit you are, the better you do. The more obese you are, the more risk factors you have for heart artery disease, the worse you do. And we're going to go through that. And what's really changed was that the guidelines prior to the 2020 really focused on that competitive, that elite high intensity physical activity and the risks associated with that. There was really little data to inform the rest of us, the normal recreational exercisers, and there was a lot of consternation, some separation between how the Europeans viewed it and how the US did. So there was an opportunity, right? It's an opportunity to move forward. And in 2020, I was part of the guideline recommendation where we described a change in how we approach this and those with HCM. There was a clear focus on sports and exercise as one of the top 10 take-home messages, and a discussion about shared decision-making in hypertrophic cardiomyopathy. Because shared decision-making really is what we do all day long, right? When if you have an HCM patient or you're going for surgery or you're doing anything else in medicine, they say no decision about me without me, right? You should be involved and engaged in your own healthcare decisions. And the HCM patient is no different. If you've been doing this long enough, you know that there's a lot that goes into being a hypertrophic cardiomyopathy patient. It might be genetic counseling. It may be decisions about a defibrillator or surgery, advanced heart failure, pregnancy. All of that discussion should go into how we care for HCM patients, and it all requires shared decision making. You're involved with all of those decisions, including lifestyle, nutrition, and exercise. Now, prior to this, most of the guidelines for sports participation started out much more restrictive. The earliest set of guidelines in 2005 basically said for our group, no competitive sports except for those classified as 1A. I can't remember exactly what the 1As are. You got to tell me there's got to be something good in there, right? What can I do if I've got HCM? Well, this is how we classified it. Across the bottom, you can see low, moderate, and high intensity for dynamic component, or the more aerobic it is, and the static component across the axis on the left. Again, low, moderate, and high based on how much weight, how heavy it is. And you can see that the class 1As are all the way down in that bottom corner. Billiards, bowling, cricket, curling, golf, and riflery were the recommended activities for those with HCM. Everything else you were told to limit. But it's more complicated than that, because we know that HCM is a risk factor for sudden death. But overall, there's a low annual mortality. Most patients with hypertrophic cardiomyopathy live well into their 80s, but there is a group within the group, especially the younger group, with particular risk factors, which we now know and have a better handle on, are at increased risk for sudden death. So I don't want you to leave thinking that this is not an important risk factor for sudden death. It clearly is. And when it is, it's a tragedy, and it gets a lot of news, and we hear a lot about it. And we should be concerned about this risk. Don't leave without that. But new estimates about HCM associated death, depending on what you're doing, your age, where you live, what stage of life you are, and of course, how thick you are, how much scar burden you have, and all the other risk factors that go into sudden death risk can vary. So we know that perhaps it's different across the board, and that symptoms don't help us. So if you look at the profile of sudden death here from Barry Marin's paper in 2007, you can see that many folks were asymptomatic, They had minimal symptoms, and the majority of them lived in who died suddenly were sedentary or doing very little, or were sleeping when they had their cardiac arrest event, suggesting this is somewhat of chance. You can risk stratify and determine who might be at high risk, but that chance really goes into the risk of sudden death in this group. So there's an opportunity to learn about more what exercise can do in hypertrophic cardiomyopathy. And we've seen some of that in the last 5 years. So here's data from the Reset HCM group. Sarah Saberi and Charlene Day from the University of Michigan looked at over 130 patients with hypertrophic cardiomyopathy, about 50 years old, and they exercised them at moderate intensity for 16 weeks. And they showed a modest increase in exercise capacity. So many of them got better, but not by a whole lot. But what was important was that there were no adverse events, no increased ventricular arrhythmias, no sudden death, shock, or death in either group. Here's a smaller study, but of younger individuals, 35 athletes with HCM, mean age about 32. Their risk score by ESC criteria was low, and they were mostly white, but they followed them up to 10 years. And there was no difference in the incidence of symptoms or events amongst those who participated or stopped competitive sports. They did have one sudden cardiac arrest event here. You can see here, this was in a tennis player, but he wasn't playing tennis, he was walking. So again, unrelated to exercise. And there are clear benefits of exercise in hypertrophic cardiomyopathy. It improves exercise tolerance. It increases your VO2 max, which is your overall exercise capacity. It potentially improves the heart remodeling, making it more favorable, improving the ability for it to relax and squeeze appropriately. We talked about the psychosocial benefits and improved mental health status, quality of life before, and these studies highlighted that, and an overall health benefits in those that increase your risk of HCM, like weight loss, metabolic profile, and makes folks live longer. So the 2020 guidelines address that and said for the as a class 1 recommendation, all patients with hypertrophic cardiomyopathy should be counseled about participating in mild to moderate intensity recreational activity because it's beneficial for their respiratory fitness. All of them should be seen by an expert to make sure that they are safe to participate and at what level they should. They also added in what's considered a 2B recommendation, which means most shouldn't participate in competitive sports, but it can be considered depending on the sport, depending on the position, depending on the individual, most importantly, once they're assessed by an expert. So somebody with expertise in both athletes and hypertrophic cardiomyopathy, that's that group that should be considered to go beyond that mild to moderate exercise. And we're seeing that across the board for recommendations for hypertrophic cardiomyopathy. In 2005, it was mostly disqualify, ineligible, and not allowed. And we're moving away from that in the 15, the 19, and the 20 guidelines. And we're now talking about engaging the athlete, the individual in their own care, and more than a yes or no, but advocating a risk assessment to determine what that individual's risk is. And that's really what shared decision making is. That's what we talked about, that it's an approach where the clinicians and the patients are going to make decisions together. It's not about the physician determining what to do or an institution depending what to do. It's an informed choice. And we do this all the time, right? We do this in medicine all the time, whether you're going for surgery, whether you're going to go drive a car, you're going to wear a helmet when you ride a bike. All of us assess our own risk on a regular basis. So are we going for just a walk, a stroll up a mountain with a loved one? Or have we decided to take it on and go all the way up the hill, where we know that for Mount Everest, about 4 in every 100 die who climb up Mount Everest. So that's more of an intermediate risk. But that high risk, what about K2, where only 300 plus people have ever stood on top of K2, that's a very high risk. Out of every 100, about 30 will die trying to get to up to the top of K2. So each of them gets to make their individual decision about risk, and the HCM patients for exercise should be the same, because your autonomy and your healthcare decision is important. Absolute risk in this condition is really difficult. Risk avoidance and acceptance is an important part of an individual decision. And we shouldn't really be taking away your identity, opportunity for scholarship and education, removing sedentary lifestyle, and improving depression and mental health concerns. All can be helped in those with exercise. So we wrote about that earlier in the year, and hopefully your physicians have looked at this, where we talked about shared decision making in athletes, and we talked about how it's teamwork, how we should be respecting the patient, the athlete's voice and their opinion. But most importantly, we said, are you having the discussion with the right provider? So when you're considering what to do, how much you can exercise, what you should be doing to prepare for it, make sure that you're engaging your healthcare provider as an expert, assuming that they have expertise in HCM and you're going to a center with expertise, to make sure that you're doing the right thing. So at every visit, when the patients come to see me, we talk about an exercise plan, and it's absolutely part of a shared decision-making discussion. I want to know what you're doing so we can advise about what those potential harms are, because most folks will make the right decision if they have an informed decision. And we do that based on your sudden cardiac arrest risk factors, your age, your sex. Do you have any symptoms? How thick are you? What's the distribution of your hypertrophic cardiomyopathy? And we often use exercise testing and your performance on an exercise test to better assess what your risk might be. And then I ask you, what are we talking about? What's sports being considered? What's the patient's risk aversion? What's your risk tolerance? Because your risk as a running back or a track athlete is different than if you're the punter on the team, or if you're participating in a lower risk sport. That conversation is different. So that exercise plan, every time we talk about it, should include a discussion about diet, about hydration, about aerobic exercise and weight training, making sure you're in a safe environment, and then the role of controlling your coronary artery disease risk factors. This is your hypertension, hypercholesterolemia, diabetes, and of course, no smoking. So let's talk about diet. Well, in the United States, we are struggling, just like around the world. Obesity accounts for a large amount of how we pay for healthcare costs. Obese individuals cost on average about a third more. We continue to get bigger with each decade. And it's not just the US, it's really a worldwide problem. We're getting bigger and bigger. And most of that, if you look at the trends, are related to caloric intake. So this is data from a huge database looking at calories intake from 1971 up to 2000. And what I can show you is that in men and women, those numbers have risen considerably. In men, it's over 150 calories per day. And in women, it's a whopping 330 plus calories per day are increased over the last 30 years. So no wonder we are struggling with our weight. And some of that is portion distortion. Here's the example of 20 years ago, what a turkey sandwich looked like. For those of you who are in your 40s and 50s like me, you remember those days when it was a normal sized turkey sandwich. And now huge subs, all of the ability to access larger volumes of sandwiches that are bloated. And the question is, what's the difference? How many calories are in that turkey sandwich? Well, the difference is 820 calories versus 300 calories, or 500 total calories have increased. So even if we think we're just having a sandwich for lunch, it's more like having nearly 3 sandwiches for lunch. And you know that maintaining a healthy weight is really a balancing act. Calories in equals calories out. So everything you take in, you got to match it with as much as you burn. So how do you compensate for that 500 calories? How much do you have to exercise? Well, it may scare you to know that you got to ride your bike for almost 90 minutes to burn off that 500 calorie difference. So have half that sandwich instead of the full sandwich, and then you won't have to ride an hour and a half. That's a lot of time needed to offset what you had for lunch. This is data from Jamil Tajik, who, if you've been doing this long enough, know he's really an expert in the field. And he says, drink more and eat less. Advice for the obstructive HCM patient. And he talks about how larger meals, heavier meals, bigger meals, more dense meals makes your obstruction worse, makes you more symptomatic. Many patients come to me and say, I'm fine until I have lunch. If after a big Thanksgiving meal, I'm taken out for the day, I literally can't walk across the room. You don't need to be a cardiologist to see that if you look at the pressure difference, the gradient in those with hypertrophic cardiomyopathy, here's what it looks like when you're fasting, same patient, postprandial meal, over 130 millimeters of mercury, and a normal is about 5 or 10 or less. So those bigger meals, they're absolutely contributing to your symptoms. So if you drink more fluid and eat less, you're going to feel better throughout the day and potentially you're going to lose weight. So lean body mass is better. Watch your calories. Your diet is what you eat. So what you consume is how you can control your weight and help you potentially with weight loss. Hydration, improving sleep, and exercise will help keep it off, but it will certainly not reduce your exercise. Your exercise will not reduce your weight as easily as just changing your diet. But what exercise, hydration, and optimal sleep do is that they do reduce the amount of hunger and the cravings you have throughout the day. So remember, your heart is a pump. And with every squeeze, the stroke volume, it needs more of it when you exercise. And it does that by making the heart bigger. So the heart dilates to compensate for that. And in HCM patients, that's particularly difficult. When you start to walk, you move blood away from the outside and up towards the lungs and the chest, as you see here, to try and compensate for that. In the HCM patients, they're super thick. The ventricle is thicker, so the cavity where all the blood is actually smaller. So you want to try and fill it up. So I talk to patients every visit about hydration and the importance of water on a regular basis. Up to an hour's worth of activity, all you need is water. As much water as you can consume, and I'll show you what that might look like. But anything greater than an hour, then you should consider sports drinks. If you have multiple same-day intense or repeated exertion throughout the day, the sports drinks can help replace those electrolytes. If it's hotter and humid out, if you're a big sweater, a salty sweater, lots of white on your hats or on your clothes, or you're not eating very much prior to participation, then those sports drinks can help with some of that blood sugar and electrolyte manifestations. So here's some data from the recommended hydration guidelines, which I find confusing, but what's helpful about it is that it does do it based on your age. So the younger you are, the older you are, of course, your needs are going to vary based on your body size. I think you'll all be surprised at how much is on here, that in your teenage years, you need somewhere between 10 and 15 cups of water, a cup being about 8 ounces of fluid. So of those Dasani big water bottles, you're going to need 4 to 5 of those on a regular basis. And for adults, it's actually double that, about 6 to 8 16-ounce bottles of water on a regular basis. That's what most of us live the day dehydrated. So hopefully this will remind you, you should have a bottle of water with you that you continually fill up throughout the day. If you're going to exercise, consider the following. 2 hours before you exercise, about 16 ounces or 1 big water. Right before you start to drink another bottle of water. And then during the event, every 20 minutes or so, consider another cup to replenish all the hydration you are losing with exercise. And then for every pound you might lose, if you're somebody who is able to monitor that throughout the day, you want to replenish every pound lost with 16 to 20 ounces of water. Now, this I find difficult to do because it doesn't really give you anything for feedback. You have to remind yourself and remember how much water you drank for the day. So think about signs of dehydration. Look for Are you are you restless? Is your mouth dry? Are you feeling thirsty? If your skin is pinchable and it holds back in place, those are indications that you're already dehydrated. But urine color is what we typically tell folks to follow. If you're an athlete or you're just a regular person who's going throughout the day, your urine color should actually be clear. It should really be more white or this light colored. So above the red line, and you are hydrated. Below the red line, the more the deeper the color, the darker the color, the more behind you are, the more dehydrated you are. So once you get to that level, you really have to spend a whole bunch of time trying to compensate. You want to stay above that red line all day, and then you know that you're feeding those muscles and you're filling up the heart so that you're not going to have symptoms. So how much exercise? How much weight training? Well, we sort of went through this briefly before, but I'll remind you, it's some combination of moderate and vigorous activity, 5 days a week for about 150 minutes in total, plus some high intensity training. Now, part of that's become complicated. Not only has the food changed over the last several decades, but so has our activity level. So if you go back 50 years ago, you might remember what this looks like. So if you were going to mow the lawn then, you're going to drag the cast iron mower out from the cellar. You're going to oil it, cut the grass, stop for a drink of water from the hose. No bottled water back then. Rake the grass, bag it, carry it across the street to the vacant lot, dump it. 3 hours spent, about 900 calories burned, and you consume 0. That's a pretty good day. But these days, it looks more like this. Open the refrigerator, take out a beer. Find your headphones and your iPod, got them both. Find the garage door opener, turn on the John Deere riding mower with the mulching option, of course. Cut the grass while sipping the beer. Total time spent 30 minutes. Calories burned 40, consumed 150. It's a little different than what it used to be. So I'll remind you that you have to move it or lose it. So it doesn't matter to me what you do, get yourself active. Just move. Whatever you're going to do, mild to moderate exercise for everyone with HCM. Of course, you're going to spend time talking to your doctor about what that safety looks like, but that mild to moderate exercise, whether it's on a treadmill or walking outside or doing an aerobics class or doing some fun skiing, downhill skiing, all of that should be part of how you move it most days of the week. So we define light exercise as walking slowly, standing while working, fishing, playing with simple instruments. All that's really not enough to get some burn. So you really need moderate exercise. Walking briskly, somewhere between 3 and 4 miles an hour. And you can usually tell that if you're having trouble having a conversation while you walk. Mowing the lawn, certainly a push mower is most important. Anytime you are riding your bicycle, you're burning at about a moderate level. Recreational badminton or tennis doubles are all appropriate. When you get more vigorous, jogging, shoveling snow, basketball game, soccer game, tennis singles, that's vigorous activity. And that really requires a conversation with your doctor about what those potential risks might be for you individually. Sometimes I will offer folks the opportunity to get on a treadmill because it's easier to sort out what your heart rate max is if I give you what those numbers are and we tell you how to stay in that stage 1 to stage 2 level, and we exercise you so that you know what your heart rate max is, what your perceived functional capacity is here in the middle, and we can give you those numbers on a regular basis. Alternatively, make it easy. Just get yourself a dog. If you own a dog, there's a large health improvement. This is an actual study, and it showed that those who have dogs will have a 22-minute additional time spent walking in a day, which equates to almost 3,000 additional steps in a day. So just owning a dog is a marker for needs for increased activity. And for those of you trying to figure out a way to get extra steps in, owning a dog is probably the simple way to do it. Now, what about weights? We talked about this being 1 to 2 days a week. We hear a lot of discussion about a maximum weight, how much weight per arm, how much total weight can I lift? And the challenge with that is that if you weigh 110 pounds and I give you a 50-pound max, that's a lot of weight. But if you're 250 and I give you a 50-pound max, that's a very different workload for you. So I don't usually use a maximum weight, but rather tell people that more repetitions is better, that I want at least 12 per muscle group, and that you shouldn't be grunting or swinging the weights or bouncing the weights off your chest when you do it. Those last 2 reps should feel like the first 2 reps of that exercise. And the design is for toning, for fitness, even cross training where you're using multiple benches or multiple activities at a time so that you can keep your heart rate up while you're getting some weight training on top of it. This is from Ben Levine, where he talks about an exercise prescription for life or for everyone who participates. And it can be in any order. Where 1 day a week, you're going to do something fun. You're going to ride a bike, go for a walk with your significant other. Maybe it's dancing. 1 day a week, you're going to do high intensity activity. He describes what's known as a 4x4, where you do 4 minutes of high intensity followed by 3 minutes of low intensity, alternating 4 times. Do that 1 day a week. That's really a higher intensity training. 2 or 3 days a week of that mild to moderate intensity exercise where you have that heart rate around 120 or so or more, just enough so you're having trouble having a conversation and breathing heavy. And then 30 minutes, at least 1 day of strength training to put on some muscle along the way. And all of that is going to go into reducing your coronary disease risk factors, because we've seen a trend in the last 20 years, not only of obesity, but we've seen some good things where smoking use has gone down. LDL cholesterol have both gone down compared to what they were pre-1980, but neither of those is associated with exercise or physical activity. But obesity, diabetes, metabolic syndrome, low HDL, higher triglycerides, those are all related to a exercise-laden lifestyle. So you're going to offset those with your exercise, assuming you're doing it safely. So if you get nothing from this lecture, think about this. This is a study of over 30 years looking at nearly 80,000 women and almost 45,000 men. They were participating in what's known as the Nurses' Health Study. And at the follow-up study, it was just do these 5 things. Don't smoke, get yourself leaner, reduce your BMI under 25, 30 minutes of moderate to vigorous activity daily, moderate alcohol, which is up to 2 drinks per day, and maintain a healthy diet. And if you do that, your life expectancy starting at 50, if you don't do that, life expectancy starting at 50 was 29 years for women and 25 for men. If you followed the just 5, all 5 of those activities, then that rose to 43 for women and 38 for men. So a pretty impressive increase in your longevity. And of course, I would argue you feel better along the way. So what's a healthy diet look like? Well, easiest way to think about this is no seconds, one plate, and make it heavy on fruits and vegetables. This is a study of almost 32,000 men and women in their mid-60s. And what they found was that if you had more fruits and vegetables on your plate, you had a reduction in cardiovascular disease, reduction in heart attack and stroke by somewhere between 20 and 30%, as you see there. And that was in addition to medication. So you didn't have to be on them or not on them. It was separate from that. You got those benefits regardless of whether or not you're on meds or not. So really what it highlights is that healthy eating substantially reduce the cardiovascular disease recurrence and ultimately is going to improve outcomes long term. And then don't forget about recovery nutrition. You got to refuel, rehydrate, and repair. And you're going to do that with carbohydrates, hydration, of course, and reducing soreness with antioxidants and mostly sleep. You really need 7 to 8 hours of sleep minimum per night in order to continue to maintain a healthy lifestyle. What about a safe environment? So this is important because we know that you can't predict this, that we know that there are some risk factors that increase the likelihood that you may have an event, but there are low-risk individuals that still can potentially have an event. So we tell you to exercise with a partner. Gyms are good. Exercise groups are good. Walking outside in a neighborhood is good. Try to avoid remote areas of hiking unless you're there with several partners who know what to do, and have a plan. Ideally, have an emergency action plan with a defibrillator to handle somebody who might collapse. If they fall unexpectedly, hands-only CPR and a defibrillator are really the best methods to make sure that folks are safe. Even during COVID, you can deliver hands-only CPR safely to somebody who collapses while we're waiting for help and or the defibrillator. I thought somebody might ask me about wearable technology. This is a huge industry and blowing up throughout healthcare. I think we're going to see more and more of this. And as a healthcare institution, we're going to have to try and sort this out over time. They're becoming more popular. They're becoming more sophisticated. And honestly, they're getting better and better. There are tons of different options. Some of them are medical grade quality. Some of them are not. I would talk to your doctor about whether or not any of these are a good option for you. And I would tell you that I view them as a positive. And I view them that if you're engaging in your own healthcare needs and monitoring your own healthcare, I think this can be a plus for you, but be careful about the amount of data that you gather from this. It can be overwhelming on the healthcare provider side, and it can also lead to some anxiety on your part. You perseverate over an extra beat here or a misread there. Your doctor can help you identify what's an important finding and what might not be something that needs to be informed. What if you have a defibrillator? Well, obviously, this is important. Many patients with HCM have a defibrillator, and we have data on that. This is from Rachel Lampert. You can see a circulation study on top and then a follow-up study in 2017. And she looked at folks in her ICD sports registry of a variety of sports, baseball, basketball, track, all across the board, whether or not they were varsity or traveling athletes or just participating in recreational sports, they were all included. All told, about 450 subjects for nearly 4 years were followed, and they found that there was an increased risk. There was not an increased risk of shock, whether or not you were exercising or not. They didn't have any injuries related to arrhythmia, and no external resuscitations were required in this group. So we know that after talking with your doctor, ask them what level of safety is appropriate for you, even if you have a defibrillator. So that's a highest risk group, but they can still find a way to exercise. And then finally, we're going to learn more, I think, in March of 2023 when we hear about this data. This is known as the LIVE HCM study, and it looked at arrhythmic events and quality of life over a 3-year period. And it was a large group of people, over 1,750 patients with HCM between age 8 and 60, with or without an ICD, and at any level of exercise, and they follow them over time. We're about to see what those numbers look like and whether or not this was as safe as we think it is to participate in hypertrophic cardiomyopathy. So I'm anxious to take some questions, and I was hoping to get to that early, so I'm going to end in a few minutes. All HCM patients should really be counseled on exercise. It should be based on individual risk assessed by your HCM expert. Each patient's highly variable. Those of you who have family members know that even within your own family, there can be a variation of hypertrophic cardiomyopathy. You might have somebody who needs a surgery and others who have no symptoms at all and feel well. So that individual expression can vary. There really is no typical HCM patients. So hopefully I'm going to encourage you to talk to your doctor about an exercise plan based on what your risk factors are, what your risk assessment is, and whatever sport you're participating in. We want you to exercise so you can have a better outcome long term. Thanks for your attention. I am happy to take questions.
Thank you so much. So with everybody listening, if you'll put your questions into the Q&A box, what amazing information. And I can tell you that I've learned that I don't drink enough water, even though I specifically tried to drink water. I'm not getting enough water, so that's not good. And I probably am not getting enough exercise, even though I attempt to do that as well. So I need to rearrange and get a little bit better on that one again. I don't have HCM, but I think that probably goes for everybody, regardless of HCM.
100%. I love the way you said that. With or without HCM, we should all be doing a better job of exercising and hydrating, for sure.
Yeah. All right. So if anybody has questions, please put them into the Q&A box, and I will moderate those out to Dr. Martinez. And it's interesting, while people are typing, I was under the assumption that if you had HCM, you were not supposed to do exercise. And so I think that this is amazing information to share, that you can live a healthy, active lifestyle with HCM.
Yeah, in fact, you're helping us if you do, because we know that if you're obese, it becomes more complicated. I can tell you that the patients, as they get older, the risk of needing a heart transplant in this condition is actually small, in the 3 to 5% range or so. But those who do need that transplant, weight plays a big factor in whether or not you're a candidate or not. So the more lean you are, the more physically fit you are, the better candidate you are. So as folks are approaching that, I have long discussions with them about how we can best lose weight for them in order to prepare themselves for the need of a transplant. And I like what you said, because the message has been confused, where we focused a lot on elite athletes and reduction of risk of sudden death in that elite athlete group, the high school athlete, the college athlete that's trying to participate. But more patients with HCM live between 30 and 60 years old. And that's the group that we want to spend time on to try and improve their overall cardiovascular fitness, because they're likely not to die from hypertrophic cardiomyopathy in that age group, but that other stuff, cancer, type 2 diabetes, kidney failure, heart artery disease, is much more likely to cause harm.
So what suggestions would you give to someone who may be elderly, over 65, not in great shape, maybe struggling with knees, backs, hips? Is there safe exercise that you could say, this might be good to talk to your doctor about doing?
So say that part again. If somebody has orthopedic stuff already and having trouble.
Yeah, because we hear a lot that there are patients are older, maybe elderly and frail, and they haven't ever exercised, and so you can't just expect them to go jump on a bike or go to a gym class. Are there safe things to start with that maybe they could talk to their doctor about?
So if you're going from ground zero, right, if you're not doing any exercise at all, some exercise is by far better than no exercise. So as long as you can do something, and maybe it's just a stroll, right, and you're just getting off the couch and you're going to try and walk for 20 minutes a day, even if you don't get up to the 3 miles an hour where you're huffing and puffing, some exercise is better than others. And the phrase is better than none, I should say. The phrase that I tell folks is that you're more likely to rust out than wear out. So the more you sit around and do nothing is a whole lot worse than worrying about wearing out those joints. You'll actually improve some of those symptoms. Pain actually with many forms of joint disease actually improves when the more you exercise. So I would tell you that start slow. Don't worry about becoming the new Lance Armstrong of your community. Any exercise is good exercise. And if you're looking for low impact stuff, certainly in a pool would be good. Spending 30 or 40 minutes in a pool where you move back and forth within the water on a bike is okay. Even a recumbent bike, which is safer. You're not likely to fall off of that if you're older and maybe have some balance issues. Any exercise you can do, anything that gets your heart rate over 100 is worth participating in. And then what usually happens is once you get that ball rolling, you start to want to do a little more. You start to feel a little better. You might have a little bit of weight loss because now your diet's changed. You're not as hungry as you were before because exercise suppresses your appetite. And the more you exercise, things start to really move in the good direction.
Fabulous. Great. I don't see any questions, which is very odd because typically we have a lot. So you must have done a really great job explaining. So I will leave you another minute if there's anything you want to share. And if not, we will thank you for your time today.
Well, thanks for having me. I'm really excited that you're doing this. I think it's such an important discussion, whether you have HCM or not. The more we exercise, the better we're going to do long term. Thanks for having me, and I'll make sure that you have updated slides.
Thank you so much. And for everyone listening, Tuesday next week at 3 o'clock Eastern time, we will be right back here with our patient panel who all have HCM and are going to tell you how they are thriving with HCM. So we'll meet you back here on Tuesday. And Dr. Martinez, thank you so much.
Thank you.
Bye-bye.
Bye, everybody.